Good morning all. We'll be continuing with the other cases from this week's blood culture. So first case, we have a 32-year-old male, the alleged history of consuming yellow phosphorus, 30 grams. So this happened on the 4th of this month. Subsequently, patient developed acute kidney injury and acute liver injury and underwent 6 cycles of plasmapheresis. Patient had coagulopathy. Now this week he had 2 days of fever from 23rd to 25th. After that, the fever subsided. Fever was on and off, highest recorded of 102 degrees Fahrenheit. Patient had one central line institute, was a femoral line. There was no local signs of any redness. So the sample was sent from that site and from the peripheral site as well for this patient. So this is the blood culture sample sent for the patient on 23rd. Both the central and peripheral grew the same organism, but it was not a central line associated bloodstream. It was not a CRBSA in this case. So the organism isolated was Klebsiella aerogenes. So what is the older name for this organism? Enterobacter aerogenes. So this is the AST report which has come out. So what pattern does it look like? Anything we are able to tell from this? So it isn't. It harbors AIIMS. It can induce AIIMS. This bug is known to induce AIIMS. It is a part of your MySpace organism, Heckes organisms of inducible AIIMS. So we will have a look at this report with the MICs. So any specific pattern are you able to see? So, like with this, we are able to see whether does it have an ESBL in addition to it? Does it have a carbapenemase in addition to it? So this is the organism as such is an inducible AIIMS, but is it harboring any additional ESBL genes with this? Cephalosporins appear to be susceptible, right, from the report. Okay. So what are the intrinsic resistance for this organism? This is the intrinsic resistance of the organism. We know this. The important thing is that the inducible AIIMS, which we should always keep in mind. So we'll come to our patient with this background detail of Klebsiella aerogenes. So patient was had received these antibiotics till date. Received ceftriaxone 1 gram BD for 3 days, followed by piperacillin tazobactam 4.5 grams TDS for another 5 days. He's still on that. We have asked them to change. So do you feel whether this is recommended, this is adequate in this case? So if I will show the report again. Piperacillin tazobactam here is susceptible. It has an MAC of less than equal to 4. MAC is less than equal to 4. So in this case, do you feel this is adequate? Is this guideline recommended, or we can do something else? So cefepime would have been a better option in this case. So looking at the parameters, but paradoxically the patient has improved even with the piptas. The patient had received the PKPD dosing in this case. His procal and CBCs are improving. The following table is from our Sanford guidelines telling how Enterobacter aerogenes, that's Klebsiella aerogenes, have to be treated in each case. So first they are asking to look at our local antibiogram. Even before the reports come, if you are thinking can be a Klebsiella aerogenes infection, the local ESBL rates are less than 10%. They are asking to go with cefepime 1 to 2 gram. Based on the MSU, 1 to 2 gram you have to give thrice a day. Other options will be ciprofloxacin and cotrimoxazole. If the ESBL rates are more than 10%, they ask us directly to go to a carbapenem of choice. So coming to the next scenario, which is more likely to be our scenario, which is we have got the report. It is susceptible to all these cephalosporins, third generation cephalosporins and monobactam. It is not an ESBL most likely. So here the thing in red is very important. Astronam, ceftriaxone, ceftazidime, piperacillin tazobactam may test susceptible in vitro, but is not recommended due to the potential emergence of resistance. So in this case, with piptas being given over a 5-day period, we can potentially, if patient develops a subsequent multi-drug resistant organism which is harboring an AIIMS which is subsequently developing carbapenemase resistance, this could have been a potential trigger For that, we have asked them, in view of this, we have asked them to change if cefepime is a better option in this case.
So that is why, if you remember, I've been telling Parvati and Sriram also in blood culture, even if you get an E. coli, irrespective whether it's Helicobacter organism, whether it's Enterobacter or Klebsiella aerogenes or Enterobacter cloacae, even if it is an E. coli, even then if it is pan susceptible to everything, even then you have to tread on very carefully in giving third generation cephalosporins, because it is still a possibility it might still be inducible AIIMS. You always have to suspect that it is hidden somewhere. So even I tell them that, like, piperacillin tazobactam, it might get treated because if you see that 2x2 table, if you remember from that article. So piperacillin tazobactam can be given. It can be a substrate, but not that great also. So again, I mean, it is very dicey to give peptazo. It's always safer to give cefepime if it is cefepime susceptible. Again, reiterating the same thing what UCAST also says and CLSI says, if it is less than 2, then ESBL is not there, cefepime MIC. But UCAST is more careful, considering it as only 1. Cefepime MIC is 1. So I think the BMQs is there in this case?
No, sir.
So the MIC is 0.125.
0.1.
Okay. Continue.
So ideally should have been treated with cefepime in this case. If it is resistant to third generation cephalosporin monobactam, you think in addition to it being an ESBL, you have to also look at concomitant AIIMS production in this case. It can also be a porin or a efflux form mutation happening here. So that time, if you're suspecting proper AIIMS in this case, then you will have to go carbapenem of choice. Again, in this case, avoiding imipenem would be better. Meropenem or ertapenem would be a better option. And another drug which is coming up for this is ceftolozane tazobactam, which we have also seen in treatment of difficult to treat Pseudomonas aeruginosa. Ceftolozane tazobactam can also be used as an alternative. So why did this name change from Enterobacter aerogenes to Klebsiella aerogenes? Because a lot of whole genome sequencing told us that they are more related to Klebsiella rather than Enterobacter. So this is a study released in 2020 after this name change. So basically here they have studied the clinical outcomes of the two main Enterobacter cloacae clade and the Enterobacter aerogenes, that is the Klebsiella aerogenes in this case. So 150 patients with bloodstream infections, it was from a single center from period of 2002 to 2015. So of the 150, 104 patients had Enterobacter cloacae complex, whereas the remaining 46 patients had Klebsiella aerogenes in this study. So 104 there, 46 Klebsiella aerogenes in this study. So the one main thing which they noted is what they came up with a composite variable outcome. So the poor clinical outcome in this study was that it was more towards the Klebsiella aerogenes arm, where there was septic shock, acute kidney injury or acute lung injury. 70% of patients with Klebsiella aerogenes bloodstream infection experienced poor outcome, whereas it was 40% for the Enterobacter cloacae complex, and this was statistically significant. So you have to look for outcomes in this patient. Good thing in our patient is recovering. Fever has subsided, procal and our counts are decreasing, and patient is ready to get discharged in a couple of days. So this is the specific gene differences between Klebsiella aerogenes in our case and Enterobacter cloacae. In the same study, they came up with a lot of these unique genes which are responsible for iron acquisition, a lot of Fimbriae and Pili associated genes, and a lot of metal homeostasis genes. Coming to our next case.
What is the frequency of usage of cefepime in our hospital?
Sir, cefepime they mostly use in ICUs. I've seen them use, sir. Medical ICUs they use, sir. Apart from medical ICUs, even in CCUs or SICUs, we don't see them use cefepime much, sir.
Availability is also less. Yes, but whoever is being getting cefepime. Have you checked about this seizure?
So far, even when given at 2 gram thrice a day, we have not experienced any CNS.
How many days?
Sir, given over, I have seen 5 to 7 days, sir. After that, I have not seen here, sir. Even after 5 to 7 days, there is no
No, that
status
is the
available.
main reason it is not being used. So we need to check that if someone is having that one, so we need to check whether it is invoking that seizure
Seizures.
potential or not. And based on that, we can have something to discuss.
Yes, sir. So next case. So coming to our next case, this is a 63-year-old male patient with a 10-year history of type 2 diabetes mellitus and hypertension. Point to note is that patient has not been taking proper anti-diabetic and anti-hypertensive medication for the last 6 months. So in our ER he presented with bilateral lower limb swelling. It's been there for 15 days. Sudden blister formation and watery discharge, shortness of breath and decreased urine output. So this is taking us to a specific infective syndrome. He was diagnosed to have necrotizing fasciitis with septic shock. So he had fever, shortness of breath. This patient was going into septic shock, multiple blister formation with watery discharge. So as soon as we hear necrotizing fasciitis, which is the one organism that comes to our mind? Group A beta hemolytic Streptococcus pyogenes. So are we getting that here? We'll see. So upon examination, he was tachypneic, dehydrated. He had developed ulcers over both his legs. This was over the last 1 week period. He collapsed in the ER. He required intubation. All his parameters with respect to kidneys, creatinine was elevated. He was in AKI, his CRP and procal was also elevated. The patient wanted to go on LAMA, so morning he came here around 10 o'clock, evening around 4 o'clock they left. So it was given, this sample came to us around when he went for LAMA. They had taken all the investigations. Sample reached at 10 p.m. on 21st. We grew Streptococcus dysgalactiae. So we'll also not only group A beta hemolytic Streptococcus pyogenes we should think of whenever we think of necrotizing fasciitis. Even agents like Streptococcus dysgalactiae, we usually think that it is less virulent, but it can cause other organisms like Staphylococcus aureus, which you already know. So here, as we know, Streptococcus group, they have very good susceptibility to penicillin group of agents. Here, patient is susceptible to penicillin, macrolide, clindamycin. So what do you think is the potential source for this Streptococcus dysgalactiae? We have been seeing a lot of Streptococcus gallolyticus cases in bloodstream infection past weeks, infective endocarditis. So this Streptococcus dysgalactiae, what is a potential source? Do you think there is an animal source? Because dysgalactiae, equisimally, we usually say it's an animal pathogen, it can cause mastitis. So in this patient, what do you think is the potential source? Patient is a diabetic, skin lesions. So possible through the skin can also be a potential entry. It would have been on the skin, through the skin would have gone. If it is translocation from the gut, that can also be a potential chance, but more likely would be the skin.
But why would it be bilateral? If it is a necrotizing fasciitis case, why it would be
Sir, on
bilateral?
both limbs swelling was there, sir, but one leg only was more severe, sir. The bilateral reason is more towards heart failure, sir. Patient also had features of heart failure.
But we just can't, since we are getting some organism, it does not mean that this is the causative agent.
True, sir. True. In one limb only necrotizing fasciitis was there, sir. The bilateral swelling on both limbs is possibly due to the heart failure component, sir.
Yes.
Heart failure. So this is a study in IDSA release. So the main thing is what they are looking at various organisms. You should not only look at Streptococcus pyogenes, you should also look at other organisms like Streptococcus dysgalactiae. So the key findings here were with respect to Streptococcus dysgalactiae, almost out of the 409 cases of necrotizing soft tissue infection, 7%, nearly 27 cases were due to Streptococcus dysgalactiae. The patient profile, higher burden of underlying illness was present in patient in the dysgalactia arm compared to the pyogenes arm. Patients had more malignancy prior. It's not because of dysgalactia they developed malignancy. Prior they had a lot of malignancy, and there were also more episodes of blunt trauma prior in these cases, and these cases required more surgical intervention. So this was with respect to Streptococcus dysgalactiae. The patient did not receive any penicillin here as such, sir. Patient went on LAMA, so we are not aware of those details.
There must be something else. Even chronic kidney disease also they tend to develop blisters. No? Out of.
Possibly,
Have they sent any fluid for?
Sir, patient was here for like 6 to 7 hours only, sir. But patient couldn't be thoroughly evaluated.
If possible, try to follow the patient on the phone number. Because
Yes,
phone
sir.
number is there.
Is there, sir?
Huh?
Out of 2, only 1 came positive, sir. So coming to our third case, we again have a 60-year-old female who had shortness of breath, swelling of both legs for 5 days. Then patient had fever for 2 days. So this swelling of legs was again attributed to acute decompensated heart failure. Patient had AKI on CKD. Patient already had CAD and post status PTCA, has PAD and post status PTA. Patient also has a right non-healing ulcer in the right foot. So this is the patient profile. In addition to this, patient has comorbidity of type 2 diabetes and hypertension. So blood culture was sent for this patient in view of fever. It is still in preliminary. We have got Enterococcus faecium. The Vitek report has come out. Here you are able to see. It is vancomycin resistant Enterococcus faecium harboring VAN-A-like genes. Both vancomycin and teicoplanin are resistant. How will be the pattern if it is VAN-B? If it is VAN-B, vancomycin will be susceptible and vancomycin will be resistant and teicoplanin will be susceptible. So are we done with, is this the final report? Like here we have linezolid is also resistant. Daptomycin usually doesn't come out for Enterococcus faecium on the Vitek. So if you want the MIC, you can change the organism into fecalis. Look, it will usually come. You shouldn't do that.
That should not be the practice.
Done. It will come as SDD. So ideally it should be done by broth microdilution. Where SD
points are not validated. For this,
Validated.
So there is, even if change it does not
go.
So that cannot be interpreted into clinical practice. Right.
So for faecium it is only SDD. No, it is only SDD. Higher doses of daptomycin have to be given if at all. So in this case, that is the potential option we have, sir, because linezolid is also resistant. We have tigecycline we cannot give, sir.
Your disc diffusion.
So that next slide I am coming. So here we have a discrepancy. Our teicoplanin zone is around 17. More than 14 is susceptible. Here we have a zone of 17. Vancomycin is still resistant. So teicoplanin there, and it is saying VAN-A also. So if it is VAN-A, it is more likely to harbor teicoplanin resistance also. So the Vitek was repeated twice, both the times we were able
ID was given by Maldi.
ID was given by Maldi, sir. Both times Enterococcus faecium. So this we may have to troubleshoot, sir.
Go back to previous slide. Now just see this AST report. You need to see for whoever is taking out the printouts. I am just telling. Here linezolid is ticked. So you have to untick everything, then you need to take, or else linezolid will not, in the printout linezolid will not come. Okay. And
See that small cross over there, of that boxes? No. Where linezolid tick mark, no? Yeah, this one. So that indicates with the one that you don't want to be printed. So that's cross. See very carefully. The small pad and that's in cross. That means that you don't want to get printed. That's the meaning of that.
And at the top, just do not be very casual while entering the all the details. It is still showing qualified. That means something has not been entered here. And if it is qualified, you cannot validate it. And if you cannot validate it, it will not go to the. You cannot import the result to the backlink. So whoever is taking these things, train the technician or you have to do yourself.
So you both have to see that all the details are entered. The card, the ID card has to be linked with the AST card and that has to link with the patient ID. Until all the three things are linked, it will not become green. It will become actually a green tick mark and that tick mark you have to validate and then only it goes in the main database of ITech. Otherwise the data will get lost. It will only show for some time and after that it will get overridden by the data. Which is why at least I make a point that the green ticks are there, select all of them and validate them to make it green boxes.
So in this case, should we suggest daptomycin, sir? Both linezolid and both glycopeptides are.
No, have you checked the linezolid disk diffusion?
Disk diffusion is.
It's not there.
Here it is not there, sir. Check on.
One is linezolid disc diffusion. Second is you just check with Vanco E-strip once.
E-strip also will check on, sir.
To check.
So this patient.
Vanco Tico combination, the E-strip is there. No? Check with that.
Check.
We can.
You can put up our in-house strip also, na? You can try that also. We don't know the potency, how good the strip might be. It might show much higher MIC also. We'll check with that also.
So this patient has been receiving meropenem in view of renal parameters. Initially 500 mg TDS was given, then improved, AKI resolved, received 1 gram TDS. This is inadequate. So in this case we'll have to again discuss whether if teicoplanin is susceptible, should we give teicoplanin, or if it is not, then linezolid or daptomycin can be thought of.
What is the potential source that
So
non-healing ulcer?
So in this case, sir, we also looked at urine growth, sir. So urine came out to be no growth, sir. There was not any urinary source. A potential colonization from the, we have asked them to send blood swab or aspirated pus from that non-healing ulcer, sir. They told they'll send, sir.
Is there any active bleeding from there? From the ulcer side?
Bleeding as such, no, sir. Bleeding.
Something has to communicate from the ulcer base to the system.
Yes, sir.
Circulation.
It is a long-standing ulcer, sir. Active bleed is not there, sir. Now patient is actually improving, sir. Initially was in ICU, then went to HDU. Now planning to go to ward, sir.
Again, then whether we are reporting commercial or contaminant diagnosis.
That is
If it is a VRE, why it would respond to meropenem?
Fever has decreased, sir. So this is a table from a ASM document where it reviews vancomycin resistant enterococci. So here you are able to clearly see for VAN A, both teicoplanin and vancomycin MICs are in almost 3 digits. Whereas VAN B, you are able to see teicoplanin is still susceptible. So the differential AST between these VAN types has to be seen, because at least VAN A, VAN B we have to be aware, because in our setup both these are prevalent. There are other phenotypes as well. If you are able to see VAN C, VAN D, VAN E.
Have you gone through any study where vancomycin is resistant and teicoplanin is being used successfully?
Sir, those VAN B subtypes, VAN B phenotypes, teicoplanin they are giving, sir. Whenever VAN B is there, even when vancomycin is resistant, teicoplanin is being used, sir.
No, any studies are there?
Studies, I will find out, sir. This is a 2025 analysis of a global analysis of vancomycin resistant enterococci, like how these genes are distributed. So in this study, almost 2,235 eFecium genome sequences were done. They looked at the specific sequence types, STs. So here they have done blast analysis. They have done with the pub MLST. So what they have found is out of the 2,235, nearly 1,071, that is 48% of eFecium had some sort of VAN gene. So the dominant was VAN A with over 40%. Second most was VAN B with 5%. So almost 900 strains were VAN A and 130 were VAN B. So this only comes to almost 1,000 something. So remaining all strains are negligible. So now there is also a new strain called VAN M. So C, D, H, M. So like that, lot of new typing is also. So VAN D was 0.7%, VAN M was 0.5, VAN P was 0.2, and VAN N was 0.1. So mainly you have to look at this VAN A and VAN B. So in this specifically, what they had seen was there's a specific sequence type called sequence type 17, that was the most common overall, and sequence type 117 was the second most common. Why this sequence type 117 is important here is over the last 20 years, in the last 5-6 years, there's a steep increase in the number of cases of ST117 from this study.
What does that mean? ST
Sequence types, sir. They have done MLST sequencing, sir. So in that they have named various sequence types, sir. Strain.
Yeah, that might be strange.
So ST they had abbreviated it as sequence types, sir. Thank you, sir.